Hello everyone, today I am here to present the updated surveillance pathway for fetal growth restriction and a small gestational age baby. These new guidelines emphasize the importance of risk assessment, classification and appropriate fetal monitoring to ensure the best possible outcomes for both mother and baby. Let's begin by defining key terms before moving on to the risk stratification and management. Before we discuss the surveillance pathway, it's important to understand some key definitions. So the first one is appropriate for gestational age. What is the appropriate range for gestational age? When the estimated fetal weight is between the 10th and 9th centile, that is appropriate for gestational age. The next one is small for gestational age. When the estimated fetal weight is below the 10th centile, that is called small for gestational age. And if it is more than 19th centile, that is called large for gestational age. So normal is between the 10th and 9th centile, small for gestational is below the 10th centile, and large for gestational age is more than 19th centile. And what is the fetal growth restriction? Fetal growth restriction is when the estimated fetal weight or abdominal circumference is below the 3rd centile, that is called fetal growth restriction. Or if the fetal weight is below the 10th centile with abnormal Doppler studies. Remember that with abnormal Doppler studies, so if it is below the 10th centile with abnormal Doppler studies, that is called fetal growth restriction. These definitions are critical for guiding clinical decisions and ensuring appropriate surveillance and management. Now let's go to the next slide. This is totally new from the previous one. So you have to read this new guideline. So this is the risk assessment and classification chart. Risk assessment is performed at the booking visit and during the mid-trimester anomaly scan. Based on the maternal, obstetric and fetal factors, patients are classified into low, moderate or high risk. Once the risk level is determined, we can establish the most suitable surveillance strategy. Look at the green pathway, that is low risk women. For women with no identified risk factors, the next step is a routine anomaly scan is performed at 20 weeks. If it is normal and the estimated fetal weight is more or equal 10 centile, the symphysiofundal height measurements are taken at every antenatal visit. If symphysiofundal height measurement remains normal, no further ultrasound scans are required. These women can follow standard antenatal care unless complications arise. Now look at the yellow section, that is moderate risk factors. These conditions slightly increase the risk of fetal growth restriction. These risk factors is important for the management purpose, so you have to know the each and every risk factors. So in moderate risk factors, there is obstetric history factors and current risk factors. In obstetric history factors, it's included previous small for gestational age baby and previous stillbirth. In current risk factor, there is current smoker, any number of cigarettes, drug misuse, women more or equal 40 years of age at booking, BMI less than 18.5 kg per meter square and other features like eating disorder, bowel disorder causing weight loss, and history of gastric bypass surgery and the history of second trimester miscarriage. That's all are in moderate risk factors. For moderate risk group people, if there is a history of placental dysfunction, consider prescribing aspirin 150 mg at night before 16 weeks of pregnancy. All women in this category require one-time symphysiofundal height measurement at 2 weeks. If anomaly scan is normal and estimated fetal weight is more or equal 10 centile, that is normal, then we can do serial ultrasonography from 32 weeks every 4 weeks until delivery. So monitoring in this group helps detect early signs of fetal growth concerns while avoiding unnecessary interventions. Now moving on to the high risk category, that is red section. These conditions significantly increase the risk of fetal growth restriction, stillbirth and adverse pregnancy outcomes. Women in this category require serial growth scans and Doppler studies for close monitoring. So in high risk factors, there is medical history factors, obstetric history factors and current pregnancy factors. In medical history, there is maternal medical conditions like chronic kidney disease, hypertension, autoimmune disease like systemic lupus erythematosus, antiphospholipid syndrome, complex cardiac disease. And in obstetric history factors, there is previous fetal growth restriction, hypertensive disease in a previous pregnancy, previous gestational age, stillbirth. In current pregnancy factors, there is pregnancy-associated plasma protein A less than 5th centile, inhibin A more than 2, multiple of median, echogenic bowel, significant bleeding, estimated fetal weight less than 10 centile, and single umbilical artery. So what is the management for high-risk group? Aspirin 150 mg at night before 16 weeks is recommended for women with hypertensive disease, previous fetal growth restriction, and estimated fetal weight less than 10 centile in a previous pregnancy. Then at 18 to 23 weeks, uterine artery Doppler is mandatory. If uterine artery Doppler is normal and estimated fetal weight is more or equal 10 centile, that is normal, then we can do serial ultrasound from 32 weeks every 2 to 4 weeks until delivery. If uterine artery Doppler is normal and estimated fetal weight is less than 10 centile, we can do serial ultrasonography from 26 to 28 weeks until delivery. If uterine artery Doppler is abnormal and the estimated fetal weight more or equal 10 centile, so we have to do serial ultrasonography from the 28 weeks every 2 to 4 weeks until delivery. If abnormal uterine artery Doppler and abdominal circumference or estimated fetal weight less than 10 centile, we have to discuss with fetal medicine unit. These high-risk pregnancies require careful monitoring to detect the growth restriction early and intervene when necessary. There is some other factors like women unsuitable for monitoring of growth by symphysiofundal height measurements, BMI more or equal 35 kg per meter square, or fibroids or congenital uterine anomalies. In that case, if anomaly scan is normal and estimated fetal weight is more or equal 10 centile, that is normal, we can do serial ultrasonography from 28 weeks in women with congenital uterine anomalies and 32 weeks in women unsuitable for symphysiofundal height every 4 weeks until delivery. Now go to the next slide. Once FGR is diagnosed, the management approach depends on the severity of Doppler findings and gestational age. Here is early FGR, that is before 32 weeks. In that case, you have to monitor fortnightly estimated fetal weight and weekly umbilical artery Doppler. If absent or reversed and diastolic flow is detected, you have to monitor at least twice weekly with continuous CTG and ductus venosus Doppler. And delivery is recommended by 32 weeks if reversed and diastolic flow persists. Next is fetal growth restriction between 32 to 36 weeks. In that case, you have to do estimated fetal weight fortnightly and umbilical artery Doppler weekly. If the fetal growth restriction is detected 32 to 33 plus 6 weeks, then the surveillance will be similar as the early FGR. If the fetal growth restriction is detected 34 to 36 plus 6 weeks and umbilical artery Doppler pulsatile index more than 95 centile, then you have to monitor minimum twice weekly continuous CTG. And the delivery is considered between 34 to 36 weeks if Doppler abnormalities are present, absent and diastolic flow is detected, and short-term variation is less than 4.5. Now the last one is late FGR, that is 37 weeks onwards. Late FGR 37 to 38 plus weeks, if abdominal circumference or estimated fetal weight less than 3rd centile, delivery should occur by 37 plus 6 weeks. If Doppler abnormalities persist, early delivery may be required. If small-for-gestational age is detected without Doppler abnormalities, delivery is recommended by 39 weeks. Immediate delivery is necessary in the following situations: spontaneous repeated decelerations on continuous CTG, maternal complications, and short-term variation less than 4.5, or reversed and diastolic flow in the umbilical artery. In these cases, delaying delivery could increase the risk of stillbirth, so urgent action is required. So these changes of new guidelines is very important for the best outcomes of the patients.